about the malignancies, but they can ask about the benign stuff too. So we'll quickly just brush up the benign stuff. I'll just go through the common ones, and then we'll focus mostly on breast carcinoma and the malignancies today. Okay. So when it comes to breast diseases, you can classify it as neoplastic and non-neoplastic. When it comes to neoplastic, again, you can classify it as benign and malignant. So for the benign one, the commonest one, I think we've all seen it in the world, it's very common, the fibroadenomas, right? So fibroadenoma, common short case. For the long case, if they can't find a breast cancer patient with a good breast lump or a breast malignancy, at that time they might even give a fibroadenoma, and then the discussion they can take it towards a malignancy later on. Then the malignancies, you have your ductal and the lobular carcinomas. We'll go into that in the management of the breast carcinomas in a bit. We'll briefly touch on the non-neoplastic conditions also. Some of the non-neoplastic conditions, such as acute mastitis, which can lead to a breast abscess. TB of the breast, or breast TB is a bit rare. Okay. Duct ectasia, that is like where there's dilatation of the duct and there's a bit of chronic inflammation going on around the duct. So this can present as a breast lump. Breast abscess can present as a breast lump. TB of the breast also can present as a breast lump. Okay, most of these conditions can present as breast lumps. Fat necrosis, that's the breast tissue has fat. So especially following trauma, there can be a bit of necrosis, and that also can present as a breast lump. Okay, so breast lumps mean they can mimic a malignancy. So these are all DDs for breast lumps and breast malignancies. Fibrocystic disease, galactosele, and then lastly gynecomastia in the males. Okay. So we'll just look at the two common benign conditions, mainly fibroadenoma and breast abscess. Fibroadenoma is the commonest benign tumor of the breast. It's common in the reproductive age group, and in the reproductive age group also commoner in an age before 30. Usually from 15 to 25 or 15 to 30 is at the commonest age group, but you can get it from 30 to 50 also. It's estrogen dependent, so sometimes with the menstrual cycles, pregnancy can increase in size. And after menopause, it can regress, because after menopause, estrogen levels reduce, so they can regress. Management is surgical excision. It's not a wide local excision. You just excise just the lump. You don't have to leave a margin as such. You just remove it with the capsule. Okay. And the other, like the clinically significant sign that you might see on examination is that it's really mobile, right? It's very hard to you can palpate it, but it slips. It's very mobile. If you have examined and seen it before, you would have noticed that. Then acute mastitis, which can lead to a breast abscess. This is common during lactation, okay? In the postpartum period during breastfeeding. Commonest causative organism is Staph aureus, because they come from the skin. So with breastfeeding, there can be cracks around the nipple-alveolar complex. So the Staph aureus in the skin, they can enter through those cracks into the ductal system, and they can result in infections and inflammations, result in accumulation of pus, which can lead to breast abscess formation. Okay. So management of that, these can be MCQ points. Okay. So feeding from the affected side, you have to encourage it. Okay. You shouldn't stop feeding just because there is an abscess. It can be painful, but if the patient can manage, if the mother can manage, you should encourage breastfeeding. Okay. And you can provide breast support, local heat and analgesia to relieve the pain. Yeah, and you have to treat with IV antibiotic. You have to give an anti-staphylococcal antibiotic. So the best one is actually flucloxacillin. Okay, so this is the anti-staphylococcal antibiotic of choice. If this is not available, you can go for coamoxicillin. And IV is better than an oral route because it's an abscess. Okay. So in the past, what they used to do for breast abscesses, they used to do the incision and drainage, but that is a bit of a more invasive procedure, right? Because they're breastfeeding. Okay, they have to look after the baby. So now what the recommendation is, to do repeated aspirations under antibiotic cover. If necessary, you can use an ultrasound for localization of the abscess, especially for smaller abscesses where you can manage with IV antibiotics. You can try this aspiration under the antibiotic cover. If it's a very big abscess, of course, then you don't go and say you'll do an aspiration under antibiotic cover. Then for very big abscesses with high fever and clinically unwell, you might have to incise and drain it. Okay, but for small abscesses, if the patient can manage, you can go for this repeated aspiration because it's less invasive and the mother can continue feeding from that side. Okay, so these can be MCQ points. They might even ask, maybe like an MCQ for example. Then we'll move on to breast carcinoma because most of the other benign conditions they haven't really questioned much, mainly fibroadenoma and breast abscesses that they've asked in the MCQs. We'll look at the breast carcinoma. This, like I said before, you can get it for the short case, the long case, MCQ, and the SCQ also. Okay. So I'm not going to go into the pathology of the breast carcinoma. You can classify it as ductal and lobular, in situ invasive. That is more of the pathology side. Okay, so we'll look at the. I'll just mostly focus on the clinical aspect of it. Okay. Before coming to this, we quickly go through like the history taking template and the examination of a breast lump. I will show the PDF for that. I think we all have this, the Longcase book that we use. I'll just quickly brush through that, go through that. And if there's any extra point, I'll let you know. So you obviously start with the demographic details, right? And I'll quickly jump to the presenting symptoms. So they usually present with a breast lump. Okay? So you have to ask the duration of the breast lump, like how long they've had it. And then you have to ask for other associated features of a breast malignancy, such as pain. Okay, pain in the breast, and that also you have to get the duration. And nipple discharge, again, for the duration. If there is a nipple discharge, you need to go into detail about the nipple discharge. Okay, like the color, the amount, which side, whether it's coming from one point of the nipple complex or multiple points, and especially if it's blood stained or not, that you will have to mention if there is a nipple discharge. Okay. Then if there's change in overlying skin or not, then the duration for that as well. And again, if there's a change, obvious change in the size and the shape, there's a massive lump. So those are the ways that they can present. Usually it's the lump, but they can present with pain, they can present with overlying skin changes, nipple discharge. Sometimes they might even just present with the axillary lump, that is the axillary lymph node, where they might not see or notice a difference in the breast. Okay, so if there's an axillary lump, it is more towards a breast malignancy or a breast lesion. So you ask all these questions also just to show that you know that you're thinking about a breast carcinoma. Okay, then the history of the presenting complaint of the lump, like how and when they first noticed the lump. Okay, progression of the lump over time, the size and all that. Any recent rapid enlargement, this is a very important negative if it's not there, because recent rapid enlargement is more towards a breast malignancy. Okay. Associated symptoms of the breast lump, like I said before, pain, alteration of nipple or skin, any discharge, if present with its color, duration, and whether they notice any other lumps on the same breast as well as the other breast as well. Some tumors, they can be multifocal. Multifocal means there are multiple tumors in the same breast. Okay, it's important to ask that also. Then we have to exclude the other DDs, other benign conditions. So fat necrosis, I told you, it is usually associated with trauma. So you have to ask about history of trauma to the breast. Then if it's a premenopausal patient, you can ask about the relationship to the size of the lump to the menstrual cycle, because there can be certain cysts that increase and decrease with the menstrual cycle. Fibroadenomas, they can increase in size depending on the menstrual cycle. Then contact history of TB and whether they have other features of TB like low-grade fever, loss of appetite, loss of weight, etc. Or past history of TB, because tuberculous mastitis can present as breast lump, but this is a bit rare. Okay, so you can put it a bit lower down in the list. And if it's a lactating mother, obviously think of an abscess. Okay. Yeah. So features suggestive of breast carcinoma, again, some points are repeated, like recent rapid enlargement, pain, overlying skin changes, and constitutional symptoms like loss of appetite, loss of weight. Like we ask for any malignancy when we think of the malignancies, ask for this as well. Then we need to ask about the features of spread. Features of metastasis of breast carcinoma, like the lymph nodes, regional lymph nodes, especially the axillary lymph nodes, whether they notice any swellings in the axilla, in the armpits. Okay. Then the lung, liver, vein and bone, like we asked for other malignancies, for the lung, chronic cough, hemoptysis, chest pain, shortness of breath, liver, the right hypochondrial pain, loss of appetite, loss of weight. Okay. Bone pain, intractable backache. Okay. These, of course, they might not present with features of hypercalcemia, but just ask 1 or 2 questions for each. Brain is the early morning headache, adult onset seizures and weakness and stuff. And anything, investigations, treatments done up to now, any pathology in the other breast. Also important to ask whether they've done any screening investigations before, have they screened for breast malignancies. Okay. And important to ask about risk factors for breast carcinoma. Okay, so main risk factors are the highest risk is if they have a first degree relative with a breast malignancy, that the BRCA gene mutation, BRCA1 and BRCA2 gene mutation, so that you can put in the family history, or you can even bring it up. It's fine if there is a positive family history, you can even tell it right in the HPC itself, depending how we want to present it. Then any condition which leads to excess estrogen, like early menarche, late menopause, nulliparity, age at first childbirth. If it's less than 30, there's like a protective risk. Okay, if the first child is born when she is less than 30 years of age, there's a not a protective risk, it's a protective factor against breast carcinoma. If the first child is born after 30 years, that protective factor is lost. Okay, so they are generally at a higher risk. Yeah, and then the number of children and the duration of breastfeeding. You need to ask specifically about the duration of breastfeeding for each child, because for them to get significant protection, they should breastfeed each child for at least 6 months. Okay, so if you ask, have they breastfed the child, and if they say yes, that's not enough. You need to ask for how long did they breastfeed each child. If it's for more than 6 months, there's significant protection from that. If it's 1 or 2 months, it's not enough. Okay? So it's important to get those minor details also. Then the past medical history, there are certain malignancies associated with breast carcinoma, like ovarian, endometrial, colorectal, gastric carcinoma even. Okay. Then exposure to ionizing radiation, these are not that common. Yeah, those are the main risk factors that you need to ask for. Then past surgical, medical, drug history, as you ask normally. Social history, you can ask about smoking, especially passive smoking. Okay, and their diet, because high fat diet is also a risk factor, like obesity, so risk factor. Yeah, and especially another, like an extra point where you don't generally ask in other histories, knowledge on self-breast examination is also important. Okay, so it's a pretty basic history. There's nothing too extra in that. On examination, the main, like the general examination, you have your own ways to do it. Mainly, you need to good to know the BMI. Okay, I think we need to get the height and weight, and because obesity is a risk factor. Okay. And then, like, sometimes because of the malignancy, the patient can be cachectic. So underweight also, it's like an extreme, the other end of it. Obesity is the risk factor. If they're cachectic, that means it could indicate like a metastatic or like a 10-stage sort of condition. Icterus can come with the liver spread. Okay. And edema of the upper limb, especially if lymph nodes are involved, there can be lymphedema of the upper limb. I'll show you some pictures later on. Okay. So those are some small points you need to look at in the general examination. So breast examination, I think I can't really show it on Zoom. So if you all are going to the wards, maybe one of these days we can come and arrange like a session to show how the breast examination is done. Okay. Mainly you need to focus on the lump. Like with the breast lump, you need to describe in detail like the site of the lump. Okay. The site you can sort of relate it with the quadrant wise, like, the upper quadrant, lower quadrant, upper outer, upper inner quadrant, and the distance you can take it from the nipple areolar complex. For example, if this is the breast, I'll just draw it here and then it. So this is the right breast, and this is the left breast, right side, left side. This is the nipple areolar complex, and there is a lump here. Okay? So I think all of you know the lump examination. I'll just tell how to like sort of present it just here. So say there's a breast like a lump here. So you start with the site. You can say there is a lump on the right breast in the upper outer quadrant. And again, you can, to be a bit more specific, you can tell the distance from the nipple areolar complex. You can say like around 3 centimeters away from the nipple areolar complex. Because upper outer quadrant, it's not that specific. It can be here, it can be here, it can be here. Okay? You can just tell it's in the upper outer quadrant around 3 or 4 centimeters away from the nipple areolar complex. Then the size, you have to tell the size in 2 dimensions. Okay? This many centimeters, this many centimeters, okay? Shape, roughly like a shape, like spherical or whatever, irregular shape. Just most of the time, malignancy, you can't tell a shape, so you can say irregular shape. Then the surface, whether it's smooth surface, irregular surface, and the margins, like well-defined margins, irregular margins. Consistency, whether it's soft, firm, or hard. Generally, malignancies tend to be hard. Okay? So these are other like small points in your examination that you need to stress on. That you have to show that if it's a malignancy, you should tell the examiner that these are the features that you look for, and these are the features that she has. So it's a hard lump. Margins, consistency, and the mobility. Mobility, you need to look at it in 2 dimensions. Okay? So you need to like sort of move the lump this way and again move the lump in a perpendicular direction. So it's a bit hard to show it over here. If we can arrange a session and go to the wards and show it, much better. Okay? Surface margins, consistency, mobility, and also tenderness. You can even tell right at the beginning, because if it's tender, your examination is limited. Okay? And whether it's attached to overlying skin and underlying muscle, that also you need to check. Then the axillary examination is also important, and you need to do the supraclavicular lymph nodes also. Okay, so that is just in brief the best examination. Yeah, and I forgot to mention on inspection, you need to comment on any obvious changes in the size. If there are any overlying skin changes to nipple areolar complex, nipple inversion, visible discharges, ulceration, destruction, any eczematous lesions, right? Any the podia range appearance, skin tethering, okay? All of that you need to do. Yeah, first basically you get the patient to sit up, and then you look for any obvious, like I said on the inspection, any changes in the size, skin changes, nipple changes, ulcerations, destructions, deviations. Okay? And then you get the patient to lie down, supine, and then you palpate. When you palpate, you first palpate the normal breast. Okay? And then you come to the side with the lump. First ask if there's pain and all that. I think that it's okay. Yeah, so this is what in the quadrants, the distance from the nipple and all that you can. Yeah. Most of the malignancies, we take it percentage wise, generally they are in the upper outer quadrant. Okay. So you describe the shape, size, surface consistency, margin, tenderness, mobility in 2 planes, attachment to skin, and underlying muscle. Okay. I think how you check if it's attached to the underlying muscle is you get the patient to press the hands firmly against the waist and move the lump in 2 directions perpendicular to the muscle fibers. Okay. Yeah, so these are some significant features of breast carcinoma, common in the upper outer quadrant, most of the malignancies, but they can be central, they can be in the quadrants, they can be the lower quadrants. Okay. There can be overlying skin changes. If there are overlying skin changes such as discolorations, ulcerations, okay, more towards the malignancy. Hard, generally malignancies are hard. It may or may not be tender. Okay? It can be non-tender also. Irregular lump, ill-defined margins, blood-stained nipple discharge, very likely to be a malignancy. Tethering or fixation, and palpable axillary lymph. So these are significant features that you need to tell. If they are there, you need to mention them. You can't miss them. If they're not there, you need to tell that they're not there also. So important positives and negatives of this box. Okay, and then in the examination, you need to look for features of spread, such as in the abdomen, you need to quickly check if there's hepatomegaly, like tender hepatomegaly. If you have time, you can check for ascites. DRE, very important. You can offer it. You don't have to do it because there can be deposits in the pouch of dark blood. You call them Blammer-Shelf tumor. Okay. And you can offer VE also because if it goes to the what you call ovaries, secondary deposits, like you can have to convert tumor. So these you can offer to show that you know that they can spread into these areas. Scalp also important because breast malignancies they spread to the bone. Commonly they spread to the bone. Okay? They're one of the common malignancies that can give lytic lesions in the bone. So breast malignancy gives rise to lytic lesions. Okay, that's another MCQ. Lytic bone lesions. Yeah, and you can do a. If you don't have time, you can even offer. You can check the spine tenderness. Again, we are looking for the bone deposits. And respiratory system examination. Again, if you have time, in the long case, quickly try and do it. Just see if the breath sounds at least equal on both sides. In the short case, of course, you can just offer it actually. Pleural effusion and consolidations. Yeah. Then we come to the staging. Staging of breast malignancy is done by the TNM. Staging. This one. Okay. TNM staging, T is for the size, N is for the lymph nodes, and M is for the distant metastasis. T1, let's ignore this T node, we remember T1 to T4. T1 is tumor size less than 2 centimeter. T2 is tumor 2 to 5 centimeter, the size. T3 is tumor size more than 5 centimeter. And T4 is any size with skin or chest wall involvement. Okay. So T4 can be further divided into T4A, B, C, and D. Okay. T4A is when there's chest wall involvement. T4B in this chest wall involvement, it means when the malignancy has spread to the ribs or the intercostal muscles, and not the pectoralis major muscle involvement. Okay, if it's attached to the pectoralis major, it's still not, we don't consider it as a chest wall involvement. Chest wall involvement means ribs or intercostal muscle involvement. Okay. Enough. So these involvement, like ulcerations, nodules. Go. Then P4C is skin and chest wall involvement. There's a P4D as well, that is when there's like an inflammatory breast cancer. Known as mastitis. Carcinoma. The T staging. T1 is less than 2, T2 is 2 to 5, T3 is more than 5 centimeters. T4 is any size with either skin or chest wall involvement. We classify it further into T4A, which is chest wall involvement, that is ribs or intercostal muscle involvement, not the pectoralis muscle, ribs or intercostal muscle. T4B is skin involvement, T4C is skin and chest wall involvement, T4D is inflammatory breast carcinoma or mastitis carcinomatosis. Okay. And the end staging is the lymph nodes. End node is no regional lymph node involvement. Like there's no regional lymph node involvement. N1 is ipsilateral mobile axillary lymph nodes. N2 is ipsilateral fixed axillary lymph nodes. N3 is ipsilateral internal thoracic lymph nodes. Those are not palpable, internal mammary or parasternal nodes. Supraclavicular nodes also you can take it for N3. That can be palpable. The internal thoracic ones you can't really palpate. That is from your investigations with CT scans and stuff, you might be able to detect that. Then M is for the distant metastasis. M node is no mets. M1 is when there is distant mets. Okay, so that is the history, and we did the history. We went to the examination roughly. Then how do we investigate? So for breast carcinoma, we have this thing called a triple assessment. Okay, so the first one is where we assess clinically, that is with the history and the examination. Okay. Then the next step is to assess radiological, that is the radiological investigation, that is the ultrasound scan and the mammogram. So generally in a patient less than 35 or less than 40, let's take it as 35 years, the breast is more sort of glandular, the ultrasound scan is better. Okay. So ultrasound scan for patients less than 35, mammogram for patients more than 35. But doing a mammogram takes time here. So till then we can do a mammogram for patients more than 35 as well. So remember it as ultrasound scan for patients less than 35. For patients more than 35, mammogram is better. But we do both, because ultrasound you can do it first and get some idea. Then they can ask for features of mammogram features of a breast malignancy. Yeah, I think this one. Characteristic features of breast carcinoma on mammography. Okay, like microcalcifications and spiculated appearance, dermal edema, distortion of architecture. Those are the four main features. Okay, microcalcifications, spiculated lesions, dermal edema, and distortion of the architecture. Okay, so those are the two radiological investigations that we mainly use. So in the triple assessment, the first one is clinical assessment, that is the history and examination. Second one is the radiological assessment, that's ultrasound and or mammo, depending on the age group. Third one is the pathological or the histopathological investigation, that is your FNAC, true cut biopsy, excision biopsy and stuff. Normally what's done is either the FNAC or the true cut biopsy. Now it's better to do the true cut biopsy. Okay, so FNAC, it's basically a fine needle aspiration cytology. You're just getting the cells. Whereas a true cut biopsy, you're doing it using a special true cut biopsy needle, a core biopsy needle, where you can get a tissue sample. In the FNAC, you're just getting a bunch of cells in the aspirate. In the true cut biopsy, you're getting a biopsy sample. Okay. So because of that, FNAC, generally you can do it. They might ask you about advantages and disadvantages about FNAC and true cut biopsy. Main advantage is about FNAC that it is a OPD procedure. And it's cheap and easy to do. Anesthesia is not required. Okay, quick. You can do it quickly. Okay, and the results also will be available. It's a cytology. You don't have to do like you don't have to fix the slide. What do you call it? Tissue sample. No? I mean, it doesn't take that much of time. You can get the results in around 2 to 3 days. Okay, whereas in the biopsy, true cut biopsy, it will take around 2 weeks. So biopsy, no? Minimal complication. You might have a bit of bruising. That's it. Okay, you might not even have the bruising. Okay, so those are the advantages. Disadvantages, there might be inadequate specimen with the FNAC. Okay, and because it's cytological diagnosis, you're just seeing the cells floating around. You're not necessarily seeing the arrangement. You don't see a basement membrane. You can't tell whether there's invasion of the malignancy through the basement membrane or not. So you can't differentiate in situ carcinomas from invasive carcinomas. And another thing is you can't assess the receptor status. And the receptor status is very important to determine the management. So when you do the management, we'll come to that receptor status. Okay, so all those disadvantages in the FNAC are advantages for the true cut biopsy. Okay, so in FNAC, we said for disadvantages, it's a cytological diagnosis. You can't differentiate between in situ and invasive. So true cut biopsy, it's an advantage. It's a tissue diagnosis where you can differentiate between in situ and invasive carcinomas. Okay. And also in FNAC, we said there's a disadvantage. You can't determine the receptor status, but true cut biopsy, you can determine the receptor status, and that's very important in the management. Okay. The disadvantages for true cut biopsy are the opposites of the advantage of the FNAC. It takes time, you need anesthesia, okay? And the results will take around 2 weeks to come. Okay, so those points, just know like 1 or 2 advantages and disadvantages for each investigation because they can ask those. So that will complete the triple assessment. Number 1 was clinical component with the history and examination. 2 is the radiological, that's the ultrasound and mammo. 3 is the histopathological, that's the FNAC and true cut biopsy. There are other ways where you can do like incision biopsy, where you make a small incision, or you can take an excision biopsy, but not commonly done. Okay, mainly now what's done is true cut biopsy. Then the other investigations to stage the disease. This depends, okay? This we don't have to do for each and everyone depending on the clinical feature that the patient has also. If there are like a sort of respiratory symptoms, you can do a chest X-ray to look for cannonball appearance. Okay, ultrasound scan of the abdomen to look for liver secondaries, ascites, lymph node involvement. We're suspecting like ovarian deposits like Gutenberg tumor. Then CT scan, contrast enhanced CT scan of chest, abdomen, pelvis. And if we're suspecting like bone deposits, you can do a bone scan. So I think there was a question in our paper also, like investigations to stage the disease, right? So you can like write these, chest X-ray to look for lung deposits like cannonball lesions, ultrasound abdomen to look for liver secondaries, ascites, lymph node. CECT, contrast enhanced CT scan of the chest, abdomen, pelvis to look for deposits. And if you're suspecting bone deposits, you can do a bone scan. Even if you're suspecting liver deposits, you can even do a liver function test. So that's just a bit on the history, examination, investigations. I think that is a bit basic. You might already know most of that. We'll go to the management. Okay, that's where we need to know a bit more of detail. Right. So management of breast carcinoma. For this, we divide breast carcinomas into 3. Here, like take this into like can write your note and properly know this because they can ask this. And this was what was asked in our papers. You divide it into 3: early breast carcinoma, locally advanced breast carcinoma, and advanced breast carcinoma. Early breast carcinoma is up to T2N1. So any tumor equal or less than T2N1 is an early breast carcinoma. Locally advanced breast carcinoma is anything more than T2N1 or anything more than T3N1. Advanced breast carcinoma is any breast carcinoma with a distant metastasis. Okay, so this is how we divide it into. Now we look at the management for each of these 3. Okay, so management of early breast carcinoma, that is once again any breast tumor that is less than or equal to T2N1. Okay, so here again we further divide the management into 3. We manage the breast, we manage the axilla, and we manage the micromodes. Those are small meds that can go around, or the other word we call it adjuvant therapy. Like we give adjuvant treatment to manage these micromets. Okay. So now we look at how we manage the breast, axilla, and the micromets in early breast carcinoma. For management of the breast, it's mainly surgical, where there are two options. We can either do a wide local excision, where we remove the tumor with 1 centimeter tumor-free margin, followed by radiotherapy. So radiotherapy is mandatory if we do a wide local excision. Okay. The other surgical option is a mastectomy with or without breast reconstruction. Okay. We can do a mastectomy without reconstruction, or we can do a mastectomy with reconstruction, depending on the age of the patient and all that. If it's a relatively young patient, most of them will opt for this reconstruction. All the patients may not really want to, because that's also another big question. Then how do we choose? So if someone asks, how do we decide between doing a wide local excision and doing a mastectomy? So these are questions that they can ask. So indications for mastectomy. It's a multifocal tumor. So multifocal tumor, like I told before, is we have the breast like this. This is the nipple complex here. If this is the tumor, it's like main tumor, and if there are like small other tumors throughout the breast, okay, in either within the same quadrant or in other quadrants as well, then definitely you can't do a wide local excision just for this. You have to take out you have to remove the entire breast. Okay, so multifocal tumors, you can't go for the wide local excision. It has to be a mastectomy. If radiotherapy is contraindicated, because for wide local excision, I told you, you have to follow it with a radiotherapy. You have to follow up with radiotherapy. It's mandatory to give radiotherapy following a wide local excision. So if you have any patient where radiotherapy is contraindicated, then you can't do a wide local excision. That is an indication for a mastectomy. Okay. For example, in pregnancy, you can't give radiotherapy, especially in first trimester, second trimester. So if there's a pregnant mother with a breast carcinoma, you have to go for a mastectomy. Connective tissue disorders, again, radiotherapy may be contraindicated. And if they were previously undergone radiotherapy to the breast, then again, radiotherapy is likely to be contraindicated. So you go for a mastectomy. When it comes to tumor size and breast size, this is more of a relative indication or contraindication for the relevant surgeries. If it's a relatively large tumor in a small breast, then doing a wide local excision is not feasible. So you might as well go for a mastectomy. Whereas if it's a relatively small tumor in a large breast, then you can go for a wide local excision. Okay, so that is relative. That depends on the patient. These two definitely, irrespective of the size and all that, you will have to go for a mastectomy if there's a multifocal tumor and if radiotherapy is controlled. Here it's a relative thing depending on the size of the breast and the tumor. If there's a recurrence of breast malignancy on the same side, on the same breast, or you have done a wide local excision, or you have done a wide local excision, but there's residual tumor, again, that's an indication for a mastectomy. Then patient preference. If the patient says she wants to remove the entire breast, then you might have to go for a mastectomy. Okay, because sometimes most of the patients think there's a breast malignancy, doing a mastectomy would be more successful than doing a wide local excision. So patients request for it. But the recurrence rates are relatively similar for both mastectomy and wide local excision. There's no big difference as such, but we have to consider the patient's preference as well. Okay, so that was also an important indication. Then indications of wide local excision are the opposites for the above mentioned ones. Okay, so that means if the tumor is not a multifocal tumor, if there's just one tumor in that quadrant, and you can remove it, then you can go for a wide local excision. If radiotherapy is not contraindicated, you can go for a wide local excision. If you take the sizes, like I said before, so if it's a relatively smaller tumor in a relatively large breast, then you can go for a wide local excision. And again, patient preference. If the patient says they want to go for a wide local excision, if you give them the option, and if the other criteria are met, you can go for the wide local excision. Okay? So these two are important. You need to know those. I think there are like 5 points. Try and remember these 5. Yeah. So then we come to types of mastectomy. So up to there, is it All right. I hope everyone got it. If there's anything, you can just let me know. You can put it on the chat box even. Yeah, up to that point, I hope it's clear. We'll move on. We'll look at the types of mastectomy. Okay. So simple mastectomy is where you excise the entire breast tissue, excision of the entire breast tissue. Then there's thing called modified radical mastectomy. This is what's commonly done. This is what's commonly done now compared to radical mastectomy. Modified radical mastectomy means you excise the entire breast tissue plus the axillary lymph node clearance is also done. So in other words, modified radical mastectomy is a simple mastectomy plus axillary lymph node clearance. Okay, once again, simple mastectomy is where you just remove the entire breast tissue. Modified radical mastectomy is where you remove the entire breast tissue, which is a simple mastectomy, and also you remove axillary lymph nodes. The axillary lymph node clearance is done. Generally, when you talk about the axillary lymph nodes, there are 3 levels: level 1, level 2, and level 3. Okay. Level 1 axillary lymph nodes are the ones that are lateral to the pec minor. Level 1 axillary lymph nodes are lateral to the pec minor. Things are so axillary lymph nodes. There are 3 levels. Level 1 is level 2 pec minor. Level 2 is beneath minor muscle. Level 3 is not medial to pec minor. So when you talk about axillary clearance, generally they clear up to level 2. They remove the level 1 lymph nodes and also the level 2 lymph nodes. Generally, that's what's done. Right? Then radical mastectomy, this is not done anymore. This was done in the past, not commonly done anymore. Okay, radical mastectomy is radical mastectomy is where you remove the entire breast tissue, you remove the axillary lymph nodes, as well as you remove the pectoralis major and the minor muscles as well. Okay. So in other words, radical mastectomy is a modified radical mastectomy plus pectoralis major and minor excision. Okay. So those are the 3 types of mastectomies. Out of those, radical mastectomy is not commonly done now. Depending on the lymph node involvement, you will go for simple mastectomy or modified radical mastectomy. For example, if there's a lymph node involvement and you have to do a mastectomy over the wide local excision, then you have to do a modified radical mastectomy. So that is the management of the breast part. So we were here, early breast carcinoma management of the breast. I told you it's mainly surgical, wide local excision and mastectomy, how to choose between the 2 and the types of mastectomies. Now we come to management of the axilla. So that again, I will draw it. So management of axilla, I think it's better if you can draw this like a flow chart. Okay. So if there are lymph node, it's a breast malignancy with lymph node positive and not malignancy with lymph node negative. Okay. Lymph node positive means either clinically palpable lymph node and image. So we classify it. Lymph node positive means either clinically when you examine either clinically when you examine, you can palpate lymph nodes, or when you image it, when you do the ultrasound or the mammo, you detect lymph nodes. Lymph nodes negative means you can't palpate them, neither can you detect them in the image. Okay. So we start with the we start with the negative and see how we manage the axilla. So if the lymph nodes are negative, then what we do is we do what is called as sentinel lymph node biopsy. We do a sentinel lymph node biopsy. That is, to do a sentinel lymph node biopsy, it's done in the theater while you are doing the surgery, either the wide local excision or the mastectomy. For this, the consultant histopathologist should be on call, should be in the lab. What you do is you inject a dye. You inject a methylene blue dye into the breast, and then you make an incision in the axilla and find out which lymph node or group of lymph nodes has taken up that blue dye, the methylene blue, and then you excise that and send it to the lab. Okay? And then you proceed with the surgery for the breast, either the wide local excision or the mastectomy, while the histopathologist at the same time goes through that biopsy specimen and checks the lymph nodes to see if there are any malignant cells. Okay, so that is what's known as a lymph node biopsy. A sentinel lymph node biopsy. So this also, so sentinel lymph node biopsy, it can come back two ways. Sentinel lymph node biopsy can come back positive, or it can come back negative. Okay. If it's negative, what you do is the surgery, or you just do the surgery best, or you don't touch the axilla anymore. You either proceed with your wide local excision, or you just do a simple mastectomy. You do a simple mastectomy where you excise the breast only. You don't remove any lymph nodes. If the sentinel lymph node biopsy comes back positive, then you have to do an axillary clearance, either wide local excision with axillary clearance or a modified radical mastectomy. Modified radical mastectomy with axillary clearance. Okay, so that's that. So once again, management of the axilla, you divide it into two: lymph node positive and lymph node negative. Lymph node positive means clinically you can palpate a group of lymph nodes, or with imaging you can detect lymph nodes in the axilla. Lymph node negative means you can't clinically palpate, and on imaging also you don't see lymph nodes. And then what you do is a sentinel lymph node biopsy. The sentinel lymph node biopsy can come back either positive or negative. Negative means there's no lymph node involvement. There's no lymph node involvement. You just proceed with the surgery for the breast. You don't mess around with the axillary lymph nodes anymore. You either go ahead with the wide local excision, or you just do the simple mastectomy. Okay. If the sentinel lymph node biopsy is positive, you have to do an axillary clearance, either the wide local excision with axillary clearance or modified radical mastectomy. All right. Then we look at this end. If the lymph nodes are positive, what we do is, even though we can palpate or we can detect it by imaging, we have to do an FNAC of we have to do an ultrasound guided FNAC of lymph node. Okay. So we have to do an ultrasound guided FNAC of the lymph nodes. And again, that also can come back as positive or negative. All right. If anyone has any questions, we can look at it. I know it's a bit late. Sorry about that. But we quickly go through this. Okay, so if there's lymph nodes positive, we can do an ultrasound guided FNAC of the lymph nodes. The FNAC of this lymph node is positive. Then again, we have to go ahead with the axillary clearance. Okay, we have to go ahead with the axillary clearance, either the wide local excision, axillary clearance, modified radical mastectomy. If the ultrasound guided FNAC of the lymph nodes is negative, then what we do is we still go for a sentinel lymph node biopsy. Yes, that is how it's done. So I hope everyone got this. Just nicely write it down and keep. I didn't put it into the slide because I want to go and explain slowly so that all of you can get it. So is there any questions with regard to the management of the axilla? Because this is the most confusing part of the CA management. The others are straightforward. If you get this, it's good. Shall I move on? Does anyone want me to explain it again? If there's any questions, just tell, or you can drop it in the chat too. Okay, I hope everyone got it. Right, let's move on. So manage axilla is done. Then we have to manage the micromets, adjuvant treatment. Adjuvant treatment there's chemotherapy, radiotherapy, hormonal therapy, and immunotherapy. Okay. Out of the adjuvant treatment, generally first is chemotherapy. Before the other adjuvant therapy, chemotherapy is done first. Because if you do the other treatments first, it can alter the sensitivity of the malignancy or the residual tumor to the chemotherapy. So chemotherapy is generally done first. These were the drugs that are given. I'm not sure if these are ones that are always given or these are some of the options. Anyway, I don't think they'll ask you for the names. Just in case, no, like 1 or 2 names. Okay, like 5-fluorouracil, cyclophosphamide, epirubicin. Okay. Those are some of the chemotherapy drugs. They won't really ask you the name of the drugs, but just in case, nice to know points. Okay. And then, like I said, it's given first before radiotherapy, hormonal therapy, and immunotherapy generally. And there are certain indications for chemotherapy. Not all the patients will get chemotherapy. Common indications are all the patients that have positive lymph nodes. Okay, even if there's one lymph node involvement, you will give chemotherapy. And triple negative breast carcinoma. Okay, triple negative breast carcinoma means I told you about immunohistochemistry in the investigation part where we do a through-cut biopsy to do the receptor status, where they find out whether there are estrogen receptors, progesterone receptors. And there's another set of receptors called HER2-neu, HER2 receptors. So triple negative means they are negative for estrogen receptor, they are negative for progesterone receptor, as well as they are negative for HER2. So triple negative breast carcinoma, you have to give chemotherapy. Okay, because for triple negative breast carcinoma, hormonal therapy and immunotherapy does not work. So it's mainly chemotherapy that we go. Then radiotherapy, there are certain indications for radiotherapy as well. It's like I said before, mandatory after wide local excision. So this is, they can incorporate this into MCQs, okay? So that's a common MCQ point. It's mandatory after wide local excision. If there are more than 4 lymph nodes involved, radiotherapy is an indication. Sometimes even with 1 lymph node involvement, radiotherapy can be considered. So this radiotherapy, if there are lymph node involvement, you can actually irradiate the axilla. You can give radiation to the axilla as well, okay, depending on the lymph node involvement. Okay, to the breast, and also you can even irradiate the axilla depending on the involvement of the lymph nodes. It's called axillary irradiation. Then hormonal therapy. That is indication for hormonal therapies if there's estrogen receptor or progesterone receptor positive breast carcinoma, you can give hormonal therapy. So that again, it depends on the menopausal state of the patient. If the patient is premenopausal, we can give tamoxifen. If the patient is postmenopausal, we give aromatase inhibitor. Commonly what is used is anastrozole. Yeah, I'll post the presentation after the lecture. I'll post all the documents and the pictures I use. So postmenopausal patients, we use aromatase inhibitors, commonly anastrozole. Another aromatase inhibitor I think you have heard about is letrozole in the Genanox. Okay, letrozole for ovulation induction. Right? So it's the same class. Here we use anastrozole for breast CA mostly. Okay. So some important notes. with regard to this, especially tamoxifen, if you remember the gin-and-nobs part of it, it increases the risk of endometrial hyperplasia and carcinoma. So remember, for endometrial hyperplasia, carcinoma, we asked if to use tamoxifen because it's a risk factor and all that. Okay, so here when we give tamoxifen, there is a risk of endometrial hyperplasia and carcinoma. So with our follow-up, we need to do a gene referral and make sure they undergo like screening for endometrial hyperplasia. They at least like a transvaginal ultrasound scan. Okay, so gene referral should be done if they are on tamoxifen. That is mandatory. And another important thing is tamoxifen also causes flushing, headache, and increased risk of DVT. Therefore, it's contraindicated in patients with past history of DVT and pulmonary embolism. Okay, so in your history, in the past medical history, you can even ask about DVT and pulmonary embolism. See, if anyone asks you why you asked, you can tell that to give tamoxifen, you need to know this history because it's contraindicated. These also can be MCQ points, okay? Tamoxifen, endometrial hyperplasia, and all that. Then immunotherapy, what's used is trastuzumab, okay? Also known as Herceptin. This is the generic name. A brand name is Herceptin. Okay. So in the case of trastuzumab is when there's HER2 positive breast carcinomas. Okay. Main adverse effect with Herceptin is that is cardiotoxic. Okay. So you might have to do a cardio referral before giving trastuzumab. Right. Okay, so that is the management of early breast carcinoma. Okay, so I told you when we manage the breast carcinoma, we divide it into early breast carcinoma, locally advanced breast carcinoma, and advanced breast carcinoma. Okay, management of early breast carcinoma, we again divide it into three. Management of the breast, management of axilla, and management of micromets or adjuvant therapy. Okay, so management of the breast was the surgical management, wide local excision or mastectomy. Management of the axilla was the flowchart I did. Okay, so memorize that nicely. And management of micromets is the four: chemo, radio, immunotherapy, and the hormonal therapy. Okay, that is the management of early breast carcinoma. And obviously, when you tell like management of breast carcinoma or any malignancy, always start with the sentence saying multidisciplinary team approach. Okay, in that you tell surgeon, anesthetist, oncologist, oncosurgeon, or radiologist, nurses, psychological support, all that. Okay, mention it because it makes the answer nicer. Even in an SCQ, nicely structures the answer. And even in the long case, if you get a breast lump or a breast carcinoma patient with a long case and they ask you how to manage, you tell like the investigations part, you continue with the triple assessment, and then for the management, say, I would approach with a multidisciplinary team, including these doctors and nurses and stuff. And then you start with the management of the breast, axilla, and the micromets. Okay, so nicely structure the answer like that. Then we look at management of locally advanced breast carcinoma. These are the malignancies that are more than T2N1 or more than T3. Okay. So here what we do is we give a neoadjuvant treatment. Neoadjuvant means before the surgery. Adjuvant means after the surgery. So we do neoadjuvant treatment where we give those adjuvant treatment before the surgery. The chemotherapy, radiotherapy, hormonal therapy, immunotherapy, depending on those indications I told you before, so we give them before surgery. Okay. And obviously before giving the neoadjuvant treatment, we need to get the receptor status. Okay. So core needle biopsy is mandatory before doing this neoadjuvant treatment. Because in order to give hormonal therapy and immunotherapy, we need to know whether the malignancy is estrogen receptor positive, progesterone receptor positive, or HER2 positive. So before that, this core needle biopsy should be done. Okay. So what happens is once we give this neoadjuvant treatment, we can downstage the carcinoma. The purpose of giving neoadjuvant treatment is to somehow try and sort of like reduce the size of this tumor burden. Okay, so when we do that, we can downstage the carcinoma to an early breast carcinoma. So something more than T2N1 you can bring it down to less than T2N1 to early breast carcinoma. And then the management is the same way as for early breast carcinoma. So we give neoadjuvant treatment, we downstage the carcinoma to an early breast carcinoma, and then manage the same way as for early breast carcinoma. Okay, in theory, that is how it can be done, but in practice, it might be a bit more difficult. Okay. Sometimes downstaging might be a bit difficult and it might just keep progressing. And if that happens, it might spread and then it becomes an advanced breast carcinoma. That is when there's a metastasis. So how we manage an advanced breast carcinoma is palliative. Okay, it's not curative, it's just end of life care. Okay. So you can give palliative chemo and radiotherapy just to reduce the tumor burden. Palliative surgery like salvage mastectomy or salvage surgery, especially if they're like large disfiguring tumors in the breast. Okay. Then we have to manage the pain. If there's any bleeding going on, we have to manage that. And psychological support, nutritional support. Okay, those things. Right. So that is the mainstay of the management of breast carcinoma. We divide it into early, locally advanced, and advanced breast carcinoma, and that's how we manage. And then another important aspect in the management, especially after this axillary clearance is done, it doesn't end there. They are when you remove the axillary lymph nodes, they're at a high risk of developing this lymphedema. So there are some advices that we give these patients following axillary clearance. Okay. So let's look at some of those. This bit was taken from this bit was taken from, there was a leaflet that they gave each patient that underwent axillary clearance at the cancer of the Maharagama hospital. It's from that. For upper limb physiotherapy, so you need to encourage them to sort of use that side. The surgery was done on the right side. You need to encourage them to get involved in general household work. So general household work can be done, such as cooking, washing, and all that. But when it comes to washing, you need to be careful because not everyone has washing machines and stuff, especially in faraway places. They carry like buckets of clothes a particular distance, like kilometers, and they go to like a close by river or a lake and stuff. And that should be discouraged because we should tell them to avoid lifting heavy weights. Okay, so if they're carrying clothes, particular like kilometers worth of distance to a nearby lake to wash clothes, that kind of washing should be discouraged. But at home, normal washing and stuff is okay. Combing hair and sketching the back, because this like encourage, like sort of improves the mobility at the shoulders. Okay, the internal rotation and external rotation is improved. So like somewhat of a physiotherapy. So avoid lifting heavy weights, especially weights more than 5 kilograms with that arm, and avoid repetitive vigorous activities such as pulling water from wells, a lot of sweeping and all that. So these are important in this social history. You might not have time to ask this in the 20 minutes. Okay, like how they get their drinking water from and all that. Okay, if you have time, you can ask, but it's important to know, especially when you're giving advice. Then avoid injury to the limb, avoid shaving the axilla because the small cuts that can happen with shaving can get infected, and because their lymphatic drainage is already compromised, it can result in lymphedema and then cellulitis and further worsening. Be cautious when cutting vegetables and fruits. They can use protective PPEs like gloves and stuff, but again, they need to be careful. And when they're cutting nails also, they need to be very careful when cutting nails. Don't cut too close to the edges and don't go too deep. Okay, because those small injuries can get infected. Okay. Yeah. Okay. And this is also important, avoid wearing tight clothing or accessories that can restrict blood and lymph drainage of the limbs. Okay, bracelets and this jewelry stuff, obviously you will tell them. But another thing is tight Philip and other bands and stuff that they wear for religious purposes should be discouraged. On that side, on the other side, they can wear anything they want. But on the side of the surgery, discourage it as much as possible, even watches and stuff. Okay, because they can restrict the blood and lymph drainage up to some extent. And also avoid wearing handbags on that side shoulder. Again, any weight or any stress on that shoulder or that arm, not good. Okay. And this was important. This is actually on our part. When obtaining medical treatment, they should always inform the doctor and the nurse about surgery. And on our part, we need to go through their medical records and we need to know on what side surgery was done, because they should avoid using that side arm for cannula insertions, blood drawing, and even blood pressure measurements. It's better not to put the cuff, BP cuff on that side and measure blood pressure. If the surgery was done on the right side, better to measure blood pressure on the left side. Okay. Cannula insertion, blood drawing, obviously do it on the opposite side. And in case of injury, seek medical advice as soon as possible. Right? So this is a picture. I think it's pretty clear that the left side, left arm, there's the patient has undergone a mastectomy and particular axillary clearance, and on the left side you can see that there's a bit of edema, it's lymphedema. Okay. So yeah, so those are the advice that you should give to prevent this. In case she does get lymphedema, you have to tell her to like keep the arm elevated and stuff. Like when they're sleeping, they can keep it at a bit of higher level, and they can put compressions. They can use compression stockings, and also massage it from distal to proximal, so that the lymph gets drained towards the axilla. Okay. And follow up. So breast carcinoma follow up, very important. It doesn't stop after the treatment. This also can be asked. Self-breast examination should be carried out monthly. So if they underwent a wide local excision, obviously on that side as well as the opposite side. But if it's a mastectomy, obviously on the opposite side. But even on the same side, even after the mastectomy, there can be recurrences on the same side. So they can just palpate that side as well and see. So self-breast examination should be taught to them. And that should be done monthly. Then 2 to 3 monthly, ideally maybe like 3 monthly, a clinical breast examination should be done on both sides. Clinical breast examination is when a healthcare worker, like a doctor or a trained sort of nurse, does the breast examination. So at clinic, that's our job as HOs and stuff. Okay, so that should be done in follow-up. Monthly, they should do the self-breast examination either in front of the mirror or a shower or before going to sleep or something on the bed, whatever that's easier for them. And with regard to investigation, 6 monthly ultrasound scan of the breast can be done, and an annual mammogram up to 5 years. So ultrasound breast on both sides, okay? Mammogram also on both sides up to 5 years. And another very important point is you need to screen the relatives, especially the female relatives. Male breast carcinoma also can occur, but it's very rare, like less than 1% or something. So if there's a patient with breast carcinoma, their mother, sister, okay, and daughters, they are old enough, should be screened. That is important. Screening again is the ultrasound and the mammo, depending on the age. Okay. Yeah, that is mainly it for the management of breast carcinoma. Any questions from that with regard to like either the benign breast disease? I didn't go into detail about there's a lot of other benign breast disease like what you call fibrocystic disease, duct ictation, and all that. I didn't go into that much detail into that because I wanted to focus mostly on breast carcinoma, management mainly. So any questions up to there? Okay, you can put it in the chat. We'll try and do some past paper questions. I didn't have time to go through the MCQs. We'll go through the SCQs. You can do the MCQs, and if there's any question, just drop me a message, okay? I'm on that, you're on that group now. We'll go through the SCQs. Yeah, so we'll see the screen. I think this paper might be a bit familiar. This is our one, the last question in the surgery paper. This is a 30-year-old. I'll discuss this because the other SCQs, I think the Fazil's has most of the answers. So this is the new one that we don't have the answers for. So I'll go through this. A 30-year-old unmarried teacher presents to the surgical clinic with a right-sided breast lump on self-examination. On examination, there's a 2.5 centimeter mobile lump in her right breast. Okay. The other breast and axilla are normal. The rest of the systemic examination is unremarkable. So list 5 possible benign conditions presenting as a breast lump in a 30-year-old patient. So this is the first slide that we went through today. Okay, I classified it to neoplastic, non-neoplastic, and then the benign condition. So commonest benign condition is a fibroadenoma. That is a neoplastic condition which is still benign. And then you can talk about the other benign condition like fat necrosis, fibrocystic disease, duct ectasia, breast abscess. Okay, any of those benign conditions can present with a lump. Okay, but put fibroadenoma as the first answer because that's the common one. And they say it's a mobile lump also. And her age also, I told you it's common for 15 to 30 years. So ideal age also. Okay. Then mention 3 investigations you would perform in this patient to diagnose this condition. So that is your triple assessment. The radiology, you can classify it and write even. You can put radiological and ultrasound there. Because it's less than 35, you can go with the ultrasound. And then for the histopathological, you can go with the FNAC, true cut biopsy. That's that. She was found to have a malignant breast lesion during investigation. Mentioned 2 risk factors for her to develop breast malignancy. So those are the risk factors we discussed. Okay. So here I think they have given some clues. So it's better if the risk factors you can give it from this stem itself. So she's unmarried. Okay, so likely to be nulliparous, right? So here, generally, when they say unmarried, they are just implying that they don't have children. So you can maybe say nulliparous. Yeah, that's actually the main clue that you get. And 30 years, I told you that after 30 years, that protection is lost. But you can just say the other risk factors, early menarche, nulliparity, maybe family history of breast carcinoma. Okay. Any 2 risk factors, better if you can give at least one of them from this 10 that they've given. Stage 2 staging investigations you would perform in this patient. So that again we went through. You can do a chest X-ray to look for the lung deposits, the cannonball lesions. You can do an ultrasound abdomen to look for liver deposits and ascites. And you can do CT, chest, abdomen, pelvis. Okay, if you're suspecting bone mets, you can do a bone scan. If I put the simple investigations first, like I think better to say like ultrasound abdomen to look for liver deposits and ascites, and CT, chest, abdomen, pelvis will cover everything. So you can put that somewhere in there to out of 2 of the answers, put that. Okay. Then staging investigations show no evidence of lymph node or distant metastasis. Based on the information provided so far, what is the stage of the disease? So no lymph node or distant metastasis. So N becomes 0, M becomes 0. So, and the size is 2.5. That is in between 2 to 5. So T2, N naught, M naught. Right? Yeah. Then what are the treatment options you offer her to manage the malignant tissue in the breast? Yeah. So this is again the surgical management. The breast title is mainly surgical, either wide local excision or mastectomy. Okay. Then state 3 options available to manage her axillary nodes. Here, this was the confusing part because they say that there's no lymph node involvement. And again, then here they're asking about managing axillary nodes. But axillary nodes, you can manage it surgically. I told you, you do the level 2 axillary clearance. Then you can give chemotherapy for the axillary nodes. I told you lymph node involvement is an indication for chemotherapy. And also you can give axillary irradiation, that is radiotherapy to the axillary nodes, especially if there's 4 or more lymph nodes involved. So surgical, you can do the axillary clearance, that's level 2 axillary clearance, chemotherapy, and axillary irradiation or radiotherapy. Okay, so those are 3 options. Then briefly describe the advice you would give a patient on discharge to prevent lymphedema following management of axillary nodes. So that's what I discussed earlier. Okay, like the physiotherapy, like minimizing injuries, avoid carrying heavy weights, avoid like wearing tight garments and bangles and all that. And when they seek medical advice, not to draw blood, not to insert cannula, Even BP cuff, better not to put on that side. And if there's any injury, to seek medical attention as soon as possible. Yeah, so that is mainly it. Are there any questions? Are there any other possible questions that you'll have doubts for? Because I think it's late now, so we can stop there. But just go through the MCQs, and if there's any hard ones, just drop me a message, okay? Most of them were straightforward. They were asking for adenomas and stuff like that, and there were like 3 questions on breast abscesses also. I could like compile them. There wasn't enough time today. But even the SCQs, there were just a few, not as common as like the urology questions. But if you come across any hard ones, just let me know, because Dr. Faz is the has the answer well, so I don't want to go through them again. This one didn't have any answer for that, so I chose this one. We can stop there if there aren't any questions. Did everyone get it? Hopefully everyone understood, so we'll stop there. Okay, thank you. Good night.